So the objectives of this short lecture are to help you recognise the role of different research designs and then to begin to critically appraise research to inform practice. And critical appraisal is becoming increasingly important given the high volume of low quality research that surrounds us. So when we say research design, we essentially refer to the approach that we're taking to answer a research question. And there are a range of different research designs. So for example, the randomized control trial, the cohort study, case control studies, qualitative studies. And it's really important to recognize that different research designs have different roles. They answer different research questions. So for example, many people would think that if you want to evaluate the effectiveness of a treatment, then the most appropriate design would be the randomized control trial. And there might be some discussion to be had around that. If you want to highlight a new or an innovative approach, then perhaps a case study or a case series would be an appropriate way to do that. If you want to track a condition over time or identify prognostic factors, then something like a cohort study would be relevant. If you want to evaluate risk factors for developing a condition, then perhaps a case control study. Or if you want to investigate a patient's experience, then perhaps you'd be thinking qualitative research. So it's really important to recognize that there isn't one design to answer every research question. We need to be more sophisticated than that. And here's a very quick overview of the range of different research designs that are on offer to us. So we've got a separation of primary or secondary research, where primary research essentially is about collecting data, in this situation, from our patients. And we can collect primary quantitative, qualitative, or mixed methods data. And within that quantitative realm, we can further subclassify into observational studies, where we don't actually offer an intervention or a treatment as part of the study. We essentially observe, measure, and evaluate what happens in usual clinical practice. But then we have these interventional studies, the focus of today's short lecture, which you might classify as the randomized controlled trial, a non-randomized trial, or an uncontrolled trial. So you will see many examples of uncontrolled trials reported at conferences, but also in the literature. So this is essentially where you take a group of patients or participants, you might offer them a treatment, and then you measure the outcome after offering the treatment. So in this situation, we don't have a control group and we have no random allocation. We have a measurement, we have an intervention, and then we repeat that measurement. And often what you'll hear on conference floors is that a speaker saying, we took this group of people, we did this treatment, whether it be exercise, manual therapy, a steroid injection, or surgery. We measured their outcomes after that treatment and they improved. So therefore, my conclusion is that this treatment is effective. And of course, this kind of research design is not capable of suggesting that a treatment is effective. Well, why? Well, because there's no control group and there's a high risk of selection bias. But if you imagine in this situation, how do we know that any change in clinical status was due to the intervention and not something else, some other treatment? Or, really importantly, perhaps they just get better with the passage of time. So these uncontrolled, these before and after studies, they might give you some useful information about a proof of concept that you can deliver an intervention, that it's not harmful, but certainly you can't infer with any confidence that a treatment is effective from this design. And then we have a non-randomized, or what some people might refer to as a quasi-experimental study. So again, we take a group of patients or research participants and we allocate them this time to a treatment and a control. So that treatment could be a program of exercise, for example. The control could be sham ultrasound. Similar process. So we'd measure the clinical status of the participants before the intervention and the control, and then we'd measure afterwards. And what some people will then attempt to do is say, well, the intervention did better than the control group, so therefore this treatment is effective. But again, that's not something you can conclude from this type of study design, because there is a high risk of what we call selection bias. In this type of study, patients are allocated in a non-random manner. So, for example, you might randomize people according to the time in which they receive surgery, perhaps within 4 weeks or beyond 4 weeks. And at the end of that, you might say, well, surgery within 4 weeks is more clinically effective than surgery after 4 weeks. But again, you can't conclude that with any confidence because of this risk of selection bias. There's a really high chance that in this context, because the two groups were formed in a non-random manner, that the two groups were different to begin with. And if the two groups are different before the treatment, then they'll be different after the treatment, and not just because of that specific treatment. So this is why we have the randomized controlled trial. And as I mentioned, many people regard this currently as the most appropriate, or perhaps the least worst research design that we have to evaluate the effectiveness of an intervention. So in this situation, what we do is we take a group of research participants. Often you take them sequentially rather than waiting to gather a whole group. And then through a process of random allocation, I'll talk more about that shortly, they are allocated to receive an intervention, such as an exercise program, or a control, such as sham ultrasound, manual therapy, injection, surgery, for example. So the idea here is that you're trying to create two groups that are not systematically different to begin with. Or in other words, perhaps too simply, but you're wanting to try and create two groups that are as similar as possible to begin with, and essentially, theoretically, the only difference between the two groups is the treatment they receive. So then if we've got two similar groups to begin with that are different at the end of the treatment, then with increasing confidence, we can attribute that difference to the treatment rather than something else. So what is randomization? I often ask people to consider whether they can define randomization without using the term random. But essentially, randomization, it's an unpredictable process. So we don't know what the next outcome will be. It's an unpredictable process, but by allocating people to two or more groups, you essentially know the chance of that allocation. So if there are two groups, we don't know what the next allocation will be, but there's a 1 in 2 chance. If we've got three groups, again, we don't know what the next allocation will be, but there's a 1 in 3 chance that the participant might be allocated to one of the treatment groups. And I mentioned this in the previous slide, but this is important. Randomization is important because we're trying to create two groups that are as similar as possible in as many factors as possible. So we've got some factors that we know about. So gender, for example. So if gender is important in terms of determining the outcome from a treatment, then we want to make sure that we've got an equal balance between the two groups, or at least the groups aren't systematically different. So that's important, and we can look at that and we can make a judgment. But importantly, what we also have are a range of factors that we don't know about that might be massively important in determining treatment outcome. And this is where randomization comes into its own. So for example, if you take a group of people with frozen shoulder or tendon-related problems, how do we know that the sugar intake in their first 5 or 10 years is not important in terms of clinical outcome? How could we even begin to measure that and then equally balance it between groups? Realistically, we can't. That's why we undertake a process of random allocation, so that we try and create two groups that are not systematically different, or they're as similar as possible on all the factors we think are important, but all the factors that might be important that we can't measure or that we don't know about. That's the whole premise of randomization. So if we can create two groups that are as similar as possible to begin with, we then deliver one or another treatment, and then we see the two groups are different at the end of those interventions and control, then with some degree of confidence we can conclude that the difference, perhaps the improved or worsening clinical outcome, is attributed to the treatment rather than some other factor. But saying that, I think it's really important to recognise the limitations of many of the randomised controlled trials that are out there at the moment. And one of the biggest issues that we see within the world of physiotherapy is that we have so many very small randomised trials. And not only does that mean that they're not big enough to detect a difference, so sometimes you might hear the term they're not adequately powered, i.e. there's not enough data there to prove that there is a difference between two groups. But one of the issues that we see with small randomised trials is an issue known as random confounding. I'd really like you to try something now, if you would, and that's to find a coin and then just to press pause on the video. And what I'm asking you to do while the video is paused is flip that coin 10 times. How many times do you get heads? Because flipping a coin essentially is a random process. And you might assume that if you flick it 10 times, you'll get 5 heads and you'll get 5 tails. But in fact, what you'll find is, and when I've done this with groups of people, some people might get 3 heads, some 4, some 5, some 6, some 7, some 8 even. So what you have through this random process, because the next flick is unpredictable, but we know there's a 50-50 chance of getting a head or a tail. Essentially, what we have by engaging with this random process is potentially we're creating 2 equal groups. So in the 3 heads scenario, we could have one group with 3 heads, one group with 7 tails, and of course we can observe that, and that's fine. But what about all the factors that we don't know about that could influence the outcome? That's why we have to be really cautious when we're looking to interpret and then implement small randomized controlled trials. It's only by elevating the numbers do you then begin to see comparability between groups. And it's a very rough rule of thumb, but you need to be looking at least 30 participants in each group for a randomized controlled trial to be approaching adequate size. But often, given how many factors we need to include, those known factors but also the unknown, typically we need much, much higher numbers to create 2 groups that are not systematically different to enable a valid comparison between 2 or more treatments. So that's something to look out for. Small trials, not just because they're not adequately powered to detect a difference, but because there's also a high risk of random confounding where groups are different to begin with. And if they're different to begin with, that means you don't have a solid platform from which to evaluate your treatment soundly. So when you look to the literature, there's a range of examples of randomized controlled trials out there. So this is the Seesaw trial. Can shoulder arthroscopy work? In this situation, there are three groups created through a random process, and these authors compared arthroscopic subacromial decompression with a placebo subacromial decompression versus a wait and see approach, so no active intervention. And it's a useful trial, published in the Lancet. It's a useful trial to pick up and read through. There are other examples of randomized trials with 3 groups, 4 groups. So for example, the UK Frost study will be published shortly. This was a 3-group randomized controlled trial, sometimes called a 3-arm randomized controlled trial, which can be a bit confusing in the shoulder world when you're talking about arms and shoulders rather than groups. But essentially, the UK Frost study randomly allocated people to a program of physiotherapy and manipulation under anaesthetic or a capsular release. There are other types of randomized trials. So we have a factorial design, and the support trial led by Keele University is an example of that. So in this situation, in a 2x2 factorial design, we have 2 factors. So in this situation, it's supervised versus non-supervised physiotherapy, and also blind versus a guided steroid injection. So those are your 2 factors, the physio, the injection, the 2 levels, supervised, non-supervised, blind or guided. And essentially what that does, it creates 4 groups, and you have the potential for multiple comparisons. There are also other randomized trials. So the crossover trial, where a patient begins with one treatment and then they cross over to receive the other treatment. And the order in which they receive that treatment is randomly allocated. That can be quite a problem in physiotherapy-related trials because let's say that you offer some advice in an exercise program. That advice, that exercise will stay with that patient. It never really washes out. So when they cross over into the other treatment, you can still have lingering effects. So really, principally, you see crossover trials in the drugs world. There are examples of cluster randomized controlled trials. So these would happen when you can't randomly allocate individual patients. So let's say, for example, you want to have a public health campaign around lifting or exercising for back pain. And what you couldn't do, for example, is put an advert on a TV, on billboards, and not expect individuals to receive that. So there are examples in the physiotherapy world where states or areas of a country are randomly allocated to receive the intervention, and that's compared against states or areas of a country where they don't receive that intervention. Other examples are randomly allocating whole GP practices rather than individuals within those GP practices, or whole schools, for example. And then, given how important patient preferences can be, that there are examples of patient preference trials where you ask people their preferences before they're randomly allocated. If they express a preference for one treatment or another, they're not randomly allocated, but they're maintained in the trial, and they're then compared against those participants who didn't express a preference for one treatment or another. They can be quite challenging trials, and some of the information around is that they don't really offer anything more than essentially asking patients for their preference if they have one before a trial, and then including that in the analysis. So that's the summary really. I've posted a link there to a blog that colleagues and I have developed over the last 2 or 3 years, and there are further examples of critical appraisal of randomized trials, and also some information about research methods that some of you might find useful. But for now, that's it. Thanks.